First, probably the boilerplate. My name is Geoff Chase. I'm a professor at the University of Canterbury. I've been here 13 years. I've come from America, so I'm a professor by job. In my own mind, I'm still a young, fit, extremely healthy athlete of about 20 less years than I have. And that is relative to metabolism. Mine has slowed down. I wish it hadn't. And this is to talk about today. We're going to talk about diabetes and metabolism, and what if we could detect it. Before that, I should point out that if there is an earthquake, there are emergency procedures for getting out of here. There are the doors at the end and the exits. Please exit in an orderly fashion. I hope not to have to actually use that in any way, shape, or form tonight. So basically, this is about a 60-minute lecture, but I'm from New Jersey, and since we're talking about physiology tonight, I'm going to explain that physiologically, the world's fastest speakers of English come from New Jersey, so we might get there in about 52 minutes, complete with an accent. And I think that afterwards we'll take questions for as long as people want to ask them. This is all being recorded for YouTube fame and glory, which is my way of saying that I'm going to think about what I say, but not too much. I am well known. There are a few of my students here for saying almost anything, so keep your eyes and ears open. Who knows what will happen? And I think with that, we'll move on. What if we could detect type 2 diabetes before it was a problem, right? And in particular, you know, maybe trying to end the social and economic impact. So we have the opening slide, the title, and a really cool mace that I thought I'd use for the talk because they told me I had to. And this will work better if I turn it on. I'm a master of technology. I want to point that out. All right. As a bit of an overview, this talk is really just a discussion. I'm going to keep it at a high level. I want to answer sort of a series of questions for a lot of people when I talk to people around the community of what I do. You know, what is diabetes actually? What is its social and economic impact? You know, is it important? What is really needed to break that cycle of misery and cost? It is a miserable disease. All right. You talk about the Chinese torture, death of 1,000 cuts. Well, diabetes is a 30-year-long prolonged bit of dying a small piece at a time. How can technology enable better answers? Because I'm an engineer, so technology is a solution to everything in my life, except for getting out for my morning run. So I should point out this talk is not for the economically squeamish. We've kind of asked a series of what-if questions. I'm going to come back to the what-if at the very end of this. Wherein, actually, to give you the end of the story before the beginning, you'll find out that I lied to you. I should point out with my students, you know, they come to ask me questions, my initial opening is, what lies can I tell you? All right, so what lies can I tell you tonight? We're going to talk about diabetes. So is it really a problem? You know, why should we be concerned about diabetes? There's cancer, pneumonia, SARS, H1N1, H5N7, all sorts of cool viruses and other stuff that kill you really quickly. Really, really quickly. I do most of my research in intensive care, so I see this, well, kind of first and a half hand. I work with a clinical colleague, Dr. Shaw, who's shown up in the front row. If the man in the blue jacket leaps up and yells, "bullshit," then you know that I've said something wrong. All right? And in particular, will diabetes alone destroy New Zealand's ability to deliver health care? For those of you that haven't maybe already lost the faith. All right? Pensions and other critical services and fund transfers and everything that this government and all prior governments of all stripes have really provided and create really the Kiwi way of life and culture of how we look at government in the world. So let's start with some definitions. Diabetes mellitus, characterized by high blood glucose levels. So this is the circulating blood sugar. We're going to call it blood glucose for the rest of the night. Hyperglycemia is the technical word, and we like to use that a lot. Due to a reduced ability of the cells throughout your body to take up glucose that's available where they store it and use it for energy. So if you want to go for a long run later, which I might want to do after this, due to my hyperactivity that you can see me as I wander around, I might want to have something to eat right now to make sure I have a little bit of energy stored on board. That is if I hadn't had lunch, which I did, which was rather large. So insulin, a hormone that your body secretes, is used to help the cells take up this glucose and store it for energy so that you have something to do later. All right? And in essence, the way your body works is you eat, you break down the food into glucose, it's absorbed by the gut, it's stored in the liver and in the cells for energy. You breathe, oxygen comes in, and oxygen, you only breathe for one purpose, and that's to burn glucose so that you can move, run, and get things done with life. Your brain uses glucose to help you think. The whole body depends on glucose. Oxygen is not actually important. It's just an enabler to help us burn glucose. At least that's what all my endocrinology friends tell me. So there's 3 types of diabetes, but really only one is of interest tonight. There's type 1. The body is unable to produce insulin. This is about 5–10% of the cases. Juvenile diabetes is often the name. Typically develops, called juvenile, when you're young or a child, and develops and goes on. You actually lose, through a viral attack, the ability to secrete insulin, and therefore your blood glucose levels rise. They're uncontrolled. It can happen to anybody at any time in life, but typically with young children and again around 18 to 21. There's gestational diabetes for pregnant women, temporary during pregnancy, a disruption to the metabolic system. And type 2, the body's resistant to insulin. It doesn't work. So insulin is the key, right? Or maybe more like money to get in. So this was free, but if you were Bruce Springsteen, who's also from New Jersey, this would cost a lot of money, right? So, you know, Bruce Springsteen, in the early days, it took only a few dollars. I was there a long time ago to get in to see Bruce Springsteen. Nowadays, it takes about $200, right? Bruce Springsteen has become money resistant. It takes more money to get in to see him, all right? Insulin resistance works the same way. Diabetes complications. Why should I care? Well, there's nerve damage. Well, that doesn't sound too bad. I mean, I've damaged lots of nerves playing sports. Blindness, that could be a problem. Kidney failure, dialysis, heart disease. Nerve damage leads to loss of feeling in the limbs. You really lose toes and then limbs. And then eventually death. All of these, by the way, because we're really not about the disease, we're engineers, we're about the money. They cost a lot of money. They occur over a long period of time. You need dialysis for 10 or 15 years. All right, that's roughly $25,000 a year to be dialyzed a couple times a week over a long period of time, and that costs money. So it's an epidemic. It's pretty well known. Here are some numbers just to scare the heck out of you. 171 million people diagnosed worldwide, expected to rise to 366. That's a doubling by 2030, and that's from 2004, so we're on the way. Equal number, roughly speaking, are undiagnosed, so they have type 2 diabetes, but they haven't seen their doctor and they don't know it. In New Zealand, it's estimated that 250,000 people will have it, and 500,000 be on the way. By 2021, that's about 15% of the population. So there are, in theory, well, judging by the number of empty seats, about 125 of you. That means that 20 of you have some form of issue, just by the stats. Total cost of diabetes in 98, 99 was $270 million. Related healthcare costs in the U.S., something like $132 billion. That number has risen. You'll see some more numbers like this later. These are big, big numbers. The main underlying cost: increased obesity, sedentary lifestyles. Approximately 1.1 billion people are overweight in the world today, in a world of 6 billion to 6.5 billion people. That's 1 out of 6. Again, about 15, 20 people. So this is just a chart that says that, well, there's a lot of diabetes around almost anywhere you go in the world, in surprising places sometimes, even in Africa, and it's going to go up over the next 20 or 30 years. Again, 220 million worldwide. Here's the big numbers. The bits in the red are the important things. That's why they're red. So 2012 cost in the U.S. about $245 billion. That's a hard number to count. All right, that's billions. 1.6% of gross domestic product. 1.6%. To give you an idea, healthcare in New Zealand costs 10% of the budget, which is less than GDP. In New Zealand, we're about 0.7% at the moment, but we're expected to rise to 1.5% by 2020 unless we do something about it. And just to be clear, this is not at all affordable. Anybody who's followed the news, for example, about budget deficits anywhere, but particularly in the Eurozone, knows that if I showed up around the Eurozone and I said, I have 1% of GDP to give back to you for free, you can just have it back. It's gone, right? I would be, the star of every single city. So why? Type 2 diabetes generally appears as you get older. Your body's ability to produce insulin does fade over time. It's a little manufacturing plant inside your body, in the pancreas, and it starts to wear out. You start to lose insulin reserves. And as we tend to live longer now than we used to when we originally evolved, some people tend to run out of insulin before they run out of life. That's a good thing in terms of living. It's a bad thing in terms of blood glucose levels. And New Zealand, like a lot of first world places, is an aging society. It generally appears if you are more sedentary. We are increasingly sedentary around the first world. We spend lots of time sitting around at desks. I recently started something because a colleague convinced me that it was only 4 days or 4 weeks instead of 4 months, carrying a little step counter around. You too. The difference is you work for her. Now, the reality is that people are becoming more sedentary. And it's kind of interesting to see that you don't even realize it. You sit in a chair, you don't realize you haven't gotten up for a little while. Compared to, say, 30, 40, 50 years ago. If I do an estimate on the average age here and then subtract 20 to be kind to people, and we say that everybody in here probably around 40 years old, including me, which would be brilliant, right? Then compared to when we were children 30 years ago, people move a lot less. They walk far less to the store. I went to the pool this morning to go for a swim, and I walked over because I live nearby, and I saw somebody circling the lot for about 3 or 4 minutes as I walked across the road and into the pool because, you know, I'm there for exercise, so I need to park as close as I can. True story. It generally appears as you get heavier. New Zealand is getting heavier because food is getting better, faster, and more tasty than ever, and it's more available. Everywhere you turn, there is food. When I was 10-ish, right, you know, it was hard to go find food. You'd have to go find a dairy or something far away. Now, you can go, and there's, 5 places right there, and there's a place just across the way there that's still open. So, we are getting older, which is bad, sedentary, which is bad, and heavier, which is bad. And they all multiply together, which gives you bad cubed, okay, which is a mathematical way of saying really, really bad, all right? And that's something that's unavoidable. There was a baby boom after World War II. There was another one in the 60s and 70s, and that is the way that is. People do get older. Better or worse yet, depending on your take on this, it has bad friends. All right, so diabetes walks hands in hand with cardiovascular disease, right? Cardiovascular disease and metabolic syndrome, as it's called, if you see these words in news articles, right? Again, increases the cost, increases the risk of early death and reduced quality of life. And no one really knows the etiology, which is just a fancy Latin word for how this comes about, or which is the chicken and which is the egg, which is the simple expression in English. But genetics plays a role, not entirely. All right. There have been several massive clinical trials. People have spent tens, and maybe more tens of millions of dollars trying to address these diseases together and separately. ACCORD, RABBIT, they always have a cool acronym. All right. Thousands of patients, tens of thousands of patients. Treatments are very much a one-size-fits-all approach, and none of them have worked. None of them have said, you know, if you do it this way, if you treat people this way, if you give them this drug and these drugs in this combination, more people will live longer. None of them have said that. And in fact, a few have said, if you do it this way, more people will live less long, and that's not so good. So there's no silver bullet. There's no easy or free solution. So everything that sort of starts out with somebody talking to a group of people who listen silently and barking in a loud voice over a microphone must be called a sit-rep. Situation report, I mean, basically, you have growing numbers of people. Every year, there's more and more people diagnosed. And it's a growing problem because every year body mass indexes tend to climb. Men and women have higher body mass indexes, a greater relative risk of type 2 diabetes because of it, and there's more and more diabetes as a result. The bad part is that it's a slow, slow, slow killer. You can live for 10 years with the onset of type 2 diabetes and not even know you have it if you don't visit your doctor or they don't take an annual blood check to look at your fasting blood glucose level. Or even if they do sometimes, as you'll see. So it kills you very, very, very slowly. But once you pass certain points, as we'll talk about, you're sort of beyond return. So the summary in words, it's often called just diabetes, but we're really talking about type 2, which is the vast majority of people. The longer you have it, the worse and more costly. As we age, more people have it, more diagnosed, even younger. In America, there are hospitals that used to take units for small children who wouldn't grow, called failure to thrive units. They're now units to address childhood obesity and childhood diabetes. In some states, and you'll find that even in New Zealand, children are being diagnosed with type 2 diabetes as young as 10 years of age. Total cost of about 2% of GDP per year is not out of the question. All right, so a solution that eliminates this cost is really what we're after. And this cost didn't exist 30 to 50 years ago. People were more active. They didn't live quite as long for a wide variety of reasons. All right, but it would certainly solve certain budget deficits. We need to address this problem. It's certainly not going away. And you can kind of view it like a bulb planted, in the autumn. It's sitting underground in winter. It's just sort of hibernating and waiting to sprout out as a flower, just not so pretty in the springtime. So let's do this in pictures, because as engineers, we do everything in pictures. So everything should be made into a simple kind of plot to kind of show the problem of what we really want to do. So you have the incidence in numbers or severity of complications, basically exposure to the disease, and the years since you were diagnosed. And this could be up to 20 or 30 years long. It ends in something called death, the black box. And it starts out, you might not even be diagnosed for a while, but you don't really feel much, see much, and eventually these grow. And you can look at the total area under here as the total cost of treating these people. So the longer somebody has it, the more complications and more they cost. Initially, you're fine. Your doctor says, well, exercise a bit more, maybe take this pill. You don't cost very much. By the time you're partly blind and you need dialysis twice a week, you cost a lot. This has huge implications for the workforce of the future, which an article in the New York Times once described as being 50% people who limp a lot or have one leg missing, who are partially blind and need time off work for 2 half days a week to go get dialyzed. This is not what the modern boss typically expects. So people are diagnosed younger, living longer, costs more. The good news is we have better drugs, better treatments, better ways to hopefully address this. You can kind of push that curve down a little bit and you can reduce the cost. Effective intervention saves lives, add quality years to life, and reduces cost. Good news. The bad news is they're not so persistent. So that means if you take these pills for years and years, they stop having the same kind of effect. You need a further or stronger treatment. Better, and what we're on about today, is early diagnosis, very early diagnosis, well before you've passed a point of no return that we'll talk about. Then you can just slide this point to the right. And that reduces cost significantly. Add it to better treatment, and you might actually have a winner that says, well, instead of 2% of GDP, how about 0.5%? Something much more affordable. So we believe very early diagnosis is actually the key. All right, better treatments. All this really shows is that the development of type 2 diabetes is actually associated with insulin resistance, low sensitivity to insulin. So basically like my Bruce Springsteen tickets, right? They're much cheaper 10 years earlier. All right, strongest predictor of type 2 diabetes risk, cardiovascular disease, everything in obese individuals and in general, right? And in particular, if you increase earlier, this is from a report for Diabetes New Zealand, you can start saving big numbers, like $16 million a year in costs, $300 million over 20 years. And as I mentioned before, it has bad friends. It also has twins. So for every person that's out there that's diagnosed, or 2 people who are diagnosed, there's 1 or 2 more who are undiagnosed. So in America, for example, the actual diagnosed number is roughly 12% of people 18 and older. And it varies by age, as you can see. But the reality is, when you do a study on it, that it looks more like 18% or maybe 20%. So for every person you know who has type 2 diabetes, there's a half or 1 more person who also has it who doesn't know. And if you want to take my word for it, everybody likes Canadians. I'm from America. That's always a bit of a political gamble, right? But this is the Canadian Diabetes Society, and they refer to it as an economic tsunami. And their cost numbers are actually higher and worse if you read this report. I would say it's less a tsunami, which happens suddenly and very fast and destroys everything, than a creeping plague that once you're seriously infected, is there forever. So early diagnosis can open new avenues to deal with this. It's all about early diagnosis. So, maybe first, by the way, we should talk about what does it really look like and how is it diagnosed now. And then later we'll talk about the technology. So here's a bit of physiology. You have your stomach and intestines. Some food comes in. It comes out. It stimulates the pancreas, which then secretes some insulin. All of this sort of goes into the liver, which takes up some of that glucose and uses some of the insulin to do it. It then goes out to the heart and circulation. And some of that glucose gets stored in the peripheral cells. Some circulates and keeps circulating until it gets stored there. The insulin goes down each time as it gets used. And our whole goal is to keep this line of circulating glucose low. High circulating glucose tends to have damaging and caustic effects. Think of it like acid in the blood, if you will. So that's your goal. So as your glucose load increases, you want to keep this steady, so you increase a little bit more insulin, and that's normally how it works. And in between meals, it goes down. But as that increases, the secretion increases, the insulin clearance, as you become a little more resistant, decreases. Your insulin sensitivity, as you become more obese, reduces, right? And that means you need more insulin to do this, which means you need a bigger green insulin arrow back here from the pancreas. Eventually, the pancreas can't put out any more, and the blood circulating levels start to increase. But this doesn't happen until you are either so resistant that your maximum secretion rate, the maximum you can put out all the time, is not enough to control it. And to give you an idea of this, most of the time, your pancreas is doing nothing. All right? So imagine it now is operating full-time all the time, can't ever recover or store more new insulin. And eventually it burns out, and this drops away, and these levels rise even faster. And effectively, you don't produce insulin anymore, and glucose levels rise and rise. And people can be in this state 8, 9, 10 years. So it looks something like this. You have what's called normal glucose tolerance, impaired, and type 2. And what really happens here is that insulin sensitivity starts to drop because you're maybe more sedentary, more obese, whatever the case may be. Eventually, your insulin production, it rises, eventually flattens out. And as a result of that, your insulin requirement, the amount you need to produce every day, goes up and up and up. And that's okay. Your glucose is still normal. If I did a fasting blood glucose measurement on you in the morning, you'd look like me and like everybody else, healthy. It's not till you reach this magic point. You've exceeded that limit. Now, all of a sudden, glucose levels start to rise just a little bit. Sensitivity keeps reducing, and eventually, the killer, your pancreas says, well, I can't produce anymore. The factory worker's been worked too hard. Boom. Over the edge we go, and we're done. And eventually they rise. Glucose levels then tend to rise. Insulin requirement is up, but you can't produce it. It goes down, and glucose levels rise out of control. So how do we diagnose it? Well, there's a really cool test called the euglycemic hyperinsulinemic clamp. It is the gold standard. It is really accurate. It just takes anywhere from 2.5 to 24 hours. It requires 2 clinicians with extensive training, lots of patient time, a really cool piece of technology called the heated handbox, plus all sorts of other measurements and things. It still only costs about $120 for the assays or the measurements that you make of blood glucose and insulin in the blood or other things. But it costs about, at a rough estimate, if you do it over 3 hours, roughly half a day, probably about $3,000 of clinician time. All right? And we make a series of glucose measurements and insulin measurements and over a series of time, and we can estimate insulin sensitivity. It says nothing about secretion, nothing about how much you're actually secreting or whether you still have any secretory capacity left. And this is the key element. That's what determines the real problem, because if you've lost this, you're not going to get it back. Anywhere along here, you can kind of recover maybe. There's the intravenous glucose tolerance test. It only takes 2 to 5 hours. It only requires 1 clinician and a rather complex mathematical model that we like a lot. It's not quite as accurate. It costs $750 plus a lot of clinician time. And there's a huge number of measurements. So you sit there with a cannula in you and somebody takes blood every 2 minutes. Brilliant for 5 hours. I've done this. It's fun. If it's your research and you get paid. Oral glucose tolerance test. This is what happens. You go to your doctor. Well, you know, you're getting on. Maybe you should give this. So they give you a big drink of glucose. And we see what happens to your glucose levels a couple hours later. And if they've come down, well, I guess you're normal. And if they haven't come down, well, I guess you've got a problem. That's really good if you want to know if you're here or there. It can't tell you if you're anywhere in between. And it only costs somewhere between $5 and $100, depending on how you do it. So it's quite cheap. It does take 2 hours of your time and leaves you feeling like crap, but it says nothing about secretion. I've done lots of those too. HOMA, homeostasis model assessment. Costs about $25, maybe $30, depending on where you get your assays done. Very little time. 1 blood glucose measurement and you're out the door. Unfortunately, the variability is 10%, which isn't too bad, to 50%. The interesting thing is that The people who invented HOMA get 10%. Everybody else gets 50%. But they have one paper, and the others have 500 papers. So, you know, obviously the one wins. So this looks like something increasing clinical intensity, increasing cost, and the increasing error. You want a highly accurate measurement. You want to know about secretion, which none of them say anything about. And it looks sort of like this. HOMA doesn't take much time or effort or cost, but you don't get much of a result. Same with the oral glucose test. And down here, it takes a lot of time and effort and money, but you get a good result. What you want to be is over here, which is what that slide says. All right? You want to know about secretion, and you want to know where you are over here. All right, so mind the numbers. To diagnose early, you need to screen everyone, even remotely at risk, which is problematic at $700 a pop for 4.2 million people and counting. Screening must be simple, accurate, repeatable. That's always good. Given the numbers involved, you want it to be low cost, right? So Zealand has 4 million people. It's easy to say that 30% would obviously, quote, require screening, and that's probably a high number. It might only be 10 or 15. But it would have to be every year. A $100 test at 30% of the population would cost something on the order of $120 million a year, and a $30 test would cost $36 million a year. And right now, we're arguing with the government just to get a small increase in what they pay us to educate, and I believe the district health board has no extra money. So a realistic goal would be $5 or $10. But as we saw, they cost, you know, once you include the clinician time, hundreds of dollars. So it seems clinical solutions or strictly medical solutions are not viable or costly. How can technology deal with this, which is why we're here tonight? So the idea is the concept of a dynamic test, right? All the other tests, they do something to you, and they wait a long time, and they see what happened. And they go, well, you started here. We expected you to end up here. You ended up there or there. I guess that's good or bad. So we want to look at the actual dynamics. There's a huge amount of data you can measure. And from that, we can determine this insulin sensitivity and the secretion. So we want to do this. We want to inject a little bit of glucose and a little bit of insulin, sample some blood, use a very fancy bit of mathematics, because otherwise it's not engineering anymore, and determine how high your insulin resistance is and get a level of that as well as your secretion. The problem is that dynamics are hard. This cartoon is actually a little bit old. It's from, I think, 79 or 89. But the reality is not much has changed. So we know that insulin comes in, there's a receptor, then something happens, and then blood glucose disappears, maybe. All right, and that's after years of research. So how are we going to solve this with a model, you might ask? So here's a picture of a model. And it's really pretty simple. It just says you have blood plasma, you have an interstitial fluid. This is where your muscles exist, and insulin can diffuse from there and glucose. And then we remove the cells. We lose insulin to the liver and the kidneys. It's produced by the pancreas, or it's given by an injection. And the liver itself creates and adds some glucose. It produces glucose when you're in between meals and you're feeling a bit low. That's your liver trying to keep you up a little bit. And you might eat a meal or otherwise have it appear. So we can take a simple picture like that of the physiology, turn it into something that's a little bit more of a complex picture, which simply says that insulin is secreted in equal measure with something called C-peptide. So that's how we can assume how much insulin is secreted, because the difference is the insulin is secreted and used, the C-peptide is secreted, and the kidney takes care of it eventually. So we can get a good idea of what your body's doing. And again, we can then relate that with this parameter SI, sensitivity to insulin, to what happens to glucose. And we can measure glucose, insulin, and C-peptide. So between that and some stuff like this, right, which is only shown to make the point that it is serious engineering and computation and not just for anybody. All right? I have an intensive care doctor here for anybody that needs resuscitation. So we have something called the DIST, the Dynamic Insulin Sensitivity and Secretion Test Protocol. All right? It's quite accurate. Repeatability is about 10%, which is about as low as it gets. It takes only 30 to 45 minutes. It requires one clinician, but not really. It just requires somebody that knows how to stick an injection needle, a phlebotomist, into a vein. It costs about $400 to $550, so I'm all the way home except for that small problem. It looks something like this. We can measure C-peptides and fit the model and insulin in the plasma and the glucose, and from all this we can determine not only your insulin sensitivity, a value for how sensitive you are, we can also determine this is your secretion of insulin profile. And what's interesting about this is that this person is relatively normal, and their blood glucose actually comes down a little bit lower. So we gave them a little dose of glucose here at about 15 minutes. And then at about 25 minutes, we gave an injection of insulin, and the glucose starts to fall. And these two people are pretty normal. That one's quite normal. They don't secrete very much. This person is probably more normal. All right, I happen to know that one's a bit athletic, at least in his own mind. This person, you can see, has a high level of secretion that jumps even higher, much higher, 10 times higher than the normal people. All right, so this is early onset. This is one of those people. You look here, though, their blood glucose at the start is normal. So they look normal. Any normal test would say they're normal. Well before 2 hours later, their blood glucose is back to normal, so any standard test says they're normal. That person's normal. They're the same as this one, except that all the curves are different. Here you have somebody. They're a long-term type 2 diabetic, but they still haven't lost all their secretion capacity. And now you see a much higher starting glucose. It's still coming down. So by an oral glucose tolerance test, they might still look normal. And then, I haven't shown it, but all these people with the euglycemic hyperinsulinemic clamp, it's got a really long name, which means it's good, they all look the same. They're all equally insulin sensitive, and they're all normal. Except they're not. For these two people, they're fine. For these two people, you want to intervene and do something. Yet, they're normal. Normal, normal, normal. Wait 5 years, we'll get them later when it's a bit too late. So the reality is we have this curve again, and the point is all these other tests tell you if you're here or if you're here. That's kind of like driving, and the only thing you can tell because your vision is limited is either I'm on the road and I'm doing well or I'm wrapped around the tree. All right? All right? Well, you know, on the road and doing well is good. Wrapped around the tree is bad, but the important bits are what happens in between. Right? That's where you'd like to take some corrective action. But if you can't see to do that, then you're stuck. So, the DIST is good, but how good is it? So we did a bit of a comparison. This is where we sell the high-quality research that we do here at the University of Canterbury, because it is. All right, we did an oral glucose tolerance test. We did the gold standard euglycemic clamp. We looked at 50 participants. They were all segregated into men and women, and they were lean and overweight and obese, and all the appropriate amounts in matching ways. All right, and any established disease, including known diabetes, were excluded. So we're looking at this as a screening test. It was well correlated to the clamp almost perfectly at 0.82. It exceeds all reported correlations for the oral glucose tolerance test. It exceeds all but one reported HOMA correlation, which was a bit dodgy. Again, if you invent it, your correlation is always much higher, it seems. All right, so I want to point out this has been repeated by people at Otago who don't like me. This exceeds almost all the IVGTT and insulin-modified ones and everything else, right? The ROC analysis, this is just a fancy way, the C unit, saying how good is a diagnostic? If you have a perfect diagnostic, your answer is 1. If you have an absolutely random diagnostic, your answer is 0.5. And if you're giving a What If Wednesday talk, it's 0.96, which is really good. Secretion data, all right, is the effective discriminator. All those people were normal, yet 50% of them need to have some kind of intervention now. Why? Because it's 2% of GDP. So we have our picture. The DIST lies somewhere here. It's still moderately intense and costly, more costly than intense, and has low error. Individual outcomes are actually better than the gold standard. So again, these are the 4 most insulin-resistant individuals from our test according to the clamp. That's a type 2 diabetic. They have almost no first-phase insulin response to glucose. There's relatively low to medium secretion, and the glucose is normal, but it's not coming down. Normal, but not coming down. So these people need an intervention. That person is normal with a slightly elevated second phase, and the reason for that is that this young woman, who secretes a bit more insulin, spends her entire day consuming only energy drinks. And so she often feels hyper and then a bit tired, and so she has another energy drink. And about 13 cans of V later, it seems, you get this. All right? But she's normal, and if she had a regular diet, she'd be even more normal, and that's the way it goes. We're talking about med students here. There's nothing normal about med students. So the reality is, you then come on, this is a normal person with a nice big first phase, low secretion levels, otherwise, and normal. Yet, these are all identified as insulin resistant by a test that doesn't really have the resolution. Where'd it go? It doesn't really have resolution across this range. All right, so you mix a poorly designed test with a lack of resolution, and you get no actual outcome to say whether somebody has a problem or not. So the reality is doctors see this a lot, and they tend to ignore it. A few others. According to the oral glucose tolerance test, this participant had reversed their type 2 diabetes, except they can't secrete insulin at all, and their blood glucose virtually never comes down. This is someone who had type 2 diabetes, had changed their lifestyle. They were running something like 10 or 15 kilometers a day every day, all right, and barely eating. And the reality was, because they don't secrete insulin, their glucose never comes down. So the person solved the problem by largely exercising lots and not eating. This is our energy drink friend again. Another one, here's a healthy, moderately sedentary individual. Normal. Here's an active individual, normal but just less secretion, and you get an actual over-response, a little bit low blood glucose. So it's capturing subtle variations between people, and more importantly, it's saying, here's a test that costs a lot of money. It says you're okay, you're okay, you're okay, but the reality is you're not. So the question is, how do we get the dist from there to there? $100 million question. So $120 million, $20 million a year wouldn't be a bad number. So real-time identification, all right? You can only use assays and measurements that are available in real time. So you'd like to actually get your answer not a week or two later, but as you leave the doctor's office. That means insulin and C-peptide assays aren't available. I won't be able to get secretion, all right? But accurate insulin concentration is critical to accurately identify insulin sensitivity. That's a problem. So I need this, but I can't have it. And a method, so we want to develop a method to estimate insulin concentration without actually having to measure it. I want to do it accurately so I capture the differences between people. All right? So the actual answer to this question, any engineering problem, is to guess scientifically. We have an acronym for it. It's called SWAG. It's called a scientific wild-ass guess. It's different than a WAG, which is merely just guessing. Scientific guessing is for engineers and people like me. So you can look at the parameters in a model, and you can take lots of data, and you can find correlations between how they behave, and these also relate an insulin sensitivity, and also between how insulin is secreted and insulin sensitivity. We can engineer this approach based on a large population of people that are all different. And what we can say is that, well, as we look at secretion over time in one of these tests, so that's one of those curves you're looking at when you look down this way, you can see that as insulin sensitivity is either very low, I have type 2 diabetes, it might rise and stay high. And otherwise, I get a first phase for very high insulin sensitivity, and it's quite low. I don't need much insulin. So we can get this variation across individuals. So that's the DIST, and it's called the quick DIST or DIST-Q. It costs $20. That's way cheaper than $455. All right, and it only takes about, 30 to 45 minutes, depending on which way you do it. All right, it requires some mathemagic. All right, but computers are also very cheap these days, so we don't need to pay attention to that slide. So we lose some quality, but is it any good? How good is it identifying insulin sensitivity? I've guessed it's secretion, but insulin sensitivity can still tell me most of the story. So we looked at 300 fully sampled DIST tests that were available, many done down at the University of Otago, who have taken up this test with quite the fervor, thankfully. And we can look at all the standard plots. And we find that instead of 0.86 to the clamp, we have 0.77. And instead of 0.96, we have 0.89, which is still really, really good. So it's actually quite equivalent to the DIST. All right. Tracking the intervention, seeing small differences. So we looked at an intervention study with small differences before and after. We said, well, I've diagnosed you, but how well is my treatment going? Are you actually exercising? Is this pill working for you? Or has it stopped working? All right, so there are pills that will help enhance your insulin sensitivity. Now you get 0.94. So very importantly, if I give you this test now and then we put you on a certain drug therapy, and I give you the test in a year, I'm very highly likely, even for very small changes in your body's response, to be able to pick out what's happened. So it's well correlated. is still a very good predictor and diagnostic. There's no significant bias against any fully sampled protocol, so you could use this in a hierarchy, by which I mean when I take this blood from you and I sample blood glucose, it only costs me $1. But that doesn't mean I can't save that blood, put your name on it, stick it in the freezer next to the ice cream, and test it later if I want to know more information about you in particular because your test result was of interest. So we're getting into the sweet spot, but $20 is still a little bit too high for my particular world. So this is kind of like let's make a deal, but we're kind of buying downwards instead of upwards. So even more frugal, can I turn $20 into $5? What will I lose? Right? I already lost secretion, but does that matter? I spent the first 44 slides or so telling you secretion mattered, but does it really? We have something called the DISQ-30. So we use much the same methods. We only take 2 samples. Costs about $5. And we correlate basically almost 100% to the fully sampled dist. We lose basically no loss of diagnostic power. We can combine the injection of glucose and insulin, something we call the DISQ-20C, all right, which sounds like a new SUV, but regardless. Still no loss of diagnostic power, just a little bit loss of 10 minutes of patient time and clinical effort. Still costs about $5. So what can I do with all these? I got $20, 455 down to 20 down to 5. All right, if only Bruce Springsteen tickets went this way. So a hierarchy, a concept, value for money spent. The reality is, for most people, I don't need a good answer. All right, so you can imagine there's a DISC, there's a DISQ. There's a whole range of things I can do along this or back down in here. All right, and in essence, I can give you one of these very short tests, and I can look at it. If the result is quite high, you're good. You're free to go. All right. If it's quite low, you're also good. You're free to go see the other doctor about your diabetes. In between, I might say, well, for a few people in between, I will take that blood back, and I'll look at C-peptide. I'll look at your secretion. I'll get a more detailed answer instead of something like this or something down here, a more detailed answer like the DIST. So we have a whole range of these tests that we've developed from $535 down to $5. The HOMA, which works really well for the people who invented it and no one else, costs $27-ish. And so I could start with this. A few people might need this, and maybe only a handful would need that. Because the whole point is not to get the total cost for everybody down, it's to get the average total cost for everybody down. Quality of results, all you really want to look at is this sort of column here, and what it's really saying is that correlation to the original fully sampled DISC, which is a very highly accurate test, is really high for almost all these tests, except for HOMA. All right, which shows what many know, that HOMA doesn't work very well. So we're not losing much diagnostic power as we throw away information, but we're not really throwing away that information. If I start here and I decide I want a higher quality result up here, I'm just a short trip to the freezer away. So I have one test protocol that can be used to generate a wide range of highly accurate tests. So the last question is, regarding the total cost, how low can I go? So I'm told that ahead of time, they gave me a briefing on this, all important talks about the broad philosophy of life, the universe, and how things work at universities should involve a slide or something that says, imagine a world where. So imagine a world where for every 100 people, 30, and this number is probably more like 15, right, could be identified just from their body shape and their lifestyle, simple questionnaire. Do you get out and walk very much? I could give every patient that came in, if I was a GP to my clinic, one of these little things. They don't cost much. You can throw them around lots. Look, I just got 5 extra steps. All right? I'll get there eventually. I give them some of that, and quite quickly I could tell who needed to be tested. I might get that down to 15, but we'll go with 30 because that'll cost more. Just based on body size, shape, history, activity levels, right? Normally the cost would be too high if I had to test everybody with the really expensive tests. Then all those who are near a borderline, not safe and not diabetic, if you will, for the $5 test, treat with a better test. And since all of your disk-derived protocols as they are use the same data points, all you have to do is assay the samples that are stored. All right, so this is easy. There's no retesting of the individual. There's no added clinician effort to do the test or any phlebotomist. All right, it's win-win-win. Should be low cost. All right, this is engineering, at least system engineering, at least a little bit near its best. We're pretty pleased with it anyway. So you can imagine this is using our own data as an example. So here's that very short disc test, and here is the gold standard. And you can imagine that anybody above this line and to the right of that line is safe. Right? And below this line, we know what your problem is as well. So the reality is, only with these red people do I need to do a retest. All right, in this case, that's about 80% or more of the people from this study. And they were all sort of at-risk kinds of individuals for the most part. I could assay the final two samples for insulin, to use this fancy acronym there. That's a $60 test. Eliminate another, say, 60% of those, so there's only 12% of the total left. Just a few red dots that I want to know more about. I can put on another threshold for $185 and get my final answer, including secretion, for those remaining people that don't lie where I understand them to be. So you can imagine, for every 1,000 individuals, right, 30% or even 15 at risk, 300 tested. You can go through this. Basically, the total cost is $7,600 or $7.60 per person for all 1,000 overall. $25.33 per person tested. That's starting to get real. That's cheaper than HOMA or OGTT or other methods when you have to test everybody. Better and better. The first year, I capture all sorts of undiagnosed type 2 diabetics. And I get an answer for most people, and I can start intervening. So only the people in that middle range probably need to come back, or I could do it every other year. I can probably get this down to something like $15 or $237 per person overall. In a country of 4 million, that's $8 million plus another third, roughly 9.3 million. All right. One of my colleagues and competitors up at Auckland just got a $4 million HRC grant. I'm sure we could spare the cash. So, you thought this talk was about diabetes. All right, this is the part where I tell you I lied, right? But what does that really mean? Well, so what? It's all actually useless. You talk to a lot of clinicians, and what they'll tell you is that, yeah, you could intervene early, change lifestyles, but the reality is that, and a huge body of literature shows that unless you live in Finland or Sweden, right, going out and convincing people to exercise, eat better, or intervening in some fashion is hard, costly, and doesn't work. All right? The counterpoint to that is that many don't start early enough in the pathogenesis to make a difference. If you walk up to somebody with a BMI of about 40 or 35 and you say, you're developing diabetes, you should get out and go for a 10K jog, it's just not going to work. All right? The trick is to get them very, very early, long before they're showing any number of these signs, and ease them into that, we believe. The counterpoint, all right, they still don't stick all the time. So what does it all mean? This is what I come to, the real what-if questions. All right, what if we had the means that enabled us to diagnose early enough that intervention worked, or could work, right? And we'd be saving significant lives and cost, right? What if this provided the opportunity to figure out how to intervene more effectively, something we don't do well at all right now? Why? Because most people say it's not worth the time and effort. But, we're looking at another 1.3% of GDP, all right? So by dint of that, that's like looking at the New Zealand budget, roughly $150 billion a year, and saying, okay, to government, I'm going to take $1.6 billion out of it. So take the budget today, which we all know is tight. Things cost too much money. We don't have enough money to provide all the services that people might want. And now we're going to take another $1.6 billion out of it. Where's it going to come from? All right? Is that not a bigger threat on the horizon? Of course, that's like a 20-year horizon away, and that's, 7 electoral cycles? So, what if we had these choices as a result and chose not to? What if we had the opportunity to redesign our cities and towns to be more friendly to the simple things that kept people active and healthier? Cycleways, buses, giving lectures where you're hyperactive and walk around a lot and toss your counter in the air to get a few extra steps. Well, I mean, that would be an actual intervention. I'd have to get ethics approval to test you. So what if we had that choice, given recent debates in the literature, not the literature, the newspapers, call it literature. Recently based in newspapers. 60 million for cycleways. My God. All right, well, you know, that's 1.6 billion for diabetes. I'm just saying. What if we chose not to? That should all sound a bit familiar. A lot of these things that we can do with policy actually come into play to how we redesign everything. Christchurch, of course, faces a really unique situation, having gone through the hard bit, to look at that and see how to change that city that maybe is actually better just from a health standpoint. What if we could see, all right, and change the future for the better? Where I forgot the and. All right, so these are the what-if questions that we like to talk about at university, right? What we've talked about tonight is really the enabler. So, you know, which is to say in conclusion, I lied to you, right? I lied in the talk, I lied in the abstract. You came to see a talk about diabetes, technology, medicine, and cool scientific wizardry. And instead, you know, the future and its issue is actually really about economics and policy, right? It's just enabled by using some technology to help begin solving that problem. So I want to end by saying that I did all this work myself because I'm a towering genius. And are there any questions? We'll leave it on the pictures of the nice-looking people. Thank you.